Marcy repair. Next. Okay, Bassini. Now Bassini is important because all of the open conventional repairs have the same set of steps that you go through to get into the inguinal canal. You may do it something different. So you make an incision, you open up the external oblique aponeurosis through the external ring. So you make a little step, open it up through the external ring, refract these leaves laterally and medially. Then classically you would divide the cremasteric muscle to mobilize the cord structures, and we usually do. Now, division of the floor of the posterior wall of the inguinal canal for its full length, that's an uncontroversial area. This is the way Bassini did the operation, and I'll show a picture of it in a second. But when this operation was imported to the U.S. from Italy, where Bassini worked, the American surgeons refused to open that posterior wall for fear of damaging structures beneath it, like the inferior epiphyseal vessels or the bladder. So that's where we got the idea of the good stuff to good stuff repair, where you just sort of sewed, you just grabbed some internal and oblique and sewed it to the inguinal ligament. Then high ligation of the index sac, we've talked about that already and how important that is. And then management of inguinal scrotal hernias, sometimes with big inguinal scrotal hernias that go all the way to the testicle, a so-called complete inguinal hernia. We sometimes just divide the sac in the internal, in the inguinal canal, rather than dig down into the scrotum and pull that out of there because the incidence of seroma is so high. But if you can get it out easily, that's probably the procedure of choice. The urologists all feel we're going to have a horrendous rate of hydroceles, but I don't see it. And I've done this many times. I don't see a lot of hydroceles. Okay, now reconstruction of the posterior wall and Bassini. Once you get the next slide. Okay, so this is showing Bassini's real operation where he divided the posterior wall, the transverse abdominal fascia. And then next slide. Okay, and then you have the famous triple layer is sutured to the inguinal ligament. That's the internal oblique transverse abdominis muscle and the cut edge of the transverse fascia. That's the so-called famous Bassini triple layer.
So
his results, of course, were outstanding, and the results, as we'll see in a minute, were not so good when they came to the United States. Next slide.
you probably mentioned it, but why divide the posterior wall, or what was the thought with?
He just felt it was very important.
Okay.
And I can't tell you the rationale, but it seemed to work. Of course, I guess that's all I can say about that.
Yeah.
Okay, Maloney Darn, what's that? That's just a darn. It just where this was very popular in the United Kingdom, and it was the precursor of the prosthetic repairs, of the Lichtenstein type prosthetic repairs, because basically what they were doing is creating a mesh by this darn. Next slide.
Shouldice.
Shouldice. What is a Shouldice repair? It's a modification of Bassini, and basically what is done is four inguinal ligaments are sort of created. So you take a suture and you suture it just like you would with Bassini in a continuous fashion to the inguinal ligament, but then you've already mobilized the inferior flap of the external oblique very significantly by opening up space below that leaf. So you create a long leaf, and then you literally create four inguinal ligaments. So you suture this way, you come back this way, with just grabbing some external oblique aponeurosis on the inferior side. You do that for four separate layers. And that's the key behind the Shouldice repair. It's technically difficult. Results are outstanding in Shouldice in Toronto. This is a picture of that. That's their results. A famous picture, it's in a lot of textbooks. But these results are not generally repeated when this operation is taken to general practice. It's too technically difficult to see exactly what they've done. You have to almost go to Toronto and watch them operate, and I've done that. But next slide, because I'll go through these pretty quickly. Now this is Cooper's ligament repair. Instead of using the inguinal ligament to do your repair, what are you using? You're using Cooper's ligament. Now what would that be good for? What hernia would that be good for? Femoral, obviously. And it's a big problem with femoral hernias. Many of the recurrent hernias are femoral, especially in males. And the reason is because if you do a Lichtenstein operation, which we're going to show in a minute, you don't look at the femoral canal. You don't see the femoral canal. So most of what we call recurrences in those situations, and there was a study done in Sweden where females presented with like a 40% recurrence rate, and it's because the Lichtenstein operation doesn't address the femoral canal. So, next slide. My last bullet point was miscellaneous repairs.
Oh.
And I just put one as, there's many of them around, where one's called the SARDA, and it's a tissue repair where you mobilize the lining of the external oblique and move it around, and they're pretty good repairs, but nobody uses them very much. But they are people that, there are a lot of patients that do not want mesh. They don't want foreign material in their bodies, and these alternative repairs can be an attractive alternative. Okay, next. So Lichtenstein, this is the most common operation done. And it's a so-called tension-free repair, because you don't suture tissues that are not naturally in apposition together like you do with the tissue repairs that we just described. So this is so-called tension-free, and the key is to suture the mesh. You open up the inguinal canal as we described in all those steps, and then you expose the pubic tubercle on the anterior rectus sheath. Put your first suture 2 centimeters meet with the pubic tubercle. Continue laterally along the inguinal ligament. I tend to pick up Cooper's ligament with the first bite, as many of you probably know, but that's not the way it's classically done. Then you got to slit the mesh laterally to go around the cord structures, and then you have to repair it. And the way Lichtenstein did it is to suture the inferior surface of the superior tail to the inferior surface of the inferior tail and the shelving edge of the inguinal ligament. Many surgeons now just close it primarily, they just reapproximate it. But that's not the way Lichtenstein described it. Then you put a few sutures into the internal oblique and the anterior rectus sheath above, and that's the repair. And then you just close the external oblique over the top. Okay, next slide. An alternative to the Lichtenstein operation is the so-called plug and patch. I'm sure many of you scrubbed on those. I can't stand the operation. I've taken so many plugs out. I think it's the stupidest operation in the world. Next slide. The point is, what you do is you take this plug and put it in your defect, and then you put a patch on top of it. Well, to me, you're just putting a Bassini. You're putting this patch in there and putting a Bassini on top of it. I mean, a Lichtenstein on top of it. Why do that? And as I say, they cause a lot of problems. I've taken many out.
Migrate.
That's it.
The patch can migrate.
Or
The plug can migrate, yes.
or it'll bunch up and they'll feel the patch.
Yeah.
Yeah, the plug can
I hate the
migrate.
patch.
It can migrate into the
Or
colon,
plug.
it can migrate into the bladder. I don't know why people do it, but they do. It's very popular. For one thing, it's very good in resident training because it's very easy to teach. So it's fast, even with the residents there. So that's why a lot of academics like it. Next slide. Okay, the preperitoneal repairs. I mean, the principle there, of course, is if you have a hole in your tire, do you want the patch on the inside where the air is going to fuse it, or do you want the patch on the outside? That was up that last slide. So the key to the preperitoneal repair is you got to figure out how to get there. Do you make an anterior groin incision and go into the preperitoneal space that way? Do you do a laparotomy, which is basically what the cheatal hernia is, and get into it that way? And same with the rope. But of course now, next slide, with laparoscopy, everything changed, because we can get into the preperitoneal space very easily, either transabdominally or extraperitoneally. So that totally really revolutionized the hernia repair, and that's actually that's how I got. It's a long story, but that's how I become a hernia expert, because of this. But I won't go into that. Next slide. So I don't think we should dwell on this. This is an external repair. You'll never do it. Let's just split that, because I know we're running out of time.
Oh, yeah, I see.
Let's go back to the Kugel.
Oh, I'm sorry?
The Kugel, go back a little bit to the Kugel. So that's a Kugel patch, and you might know that this is the one where the ring, that ring fractured and caused a lot of complications that when the early was developed. The principle here is you can make a teeny little incision, get into the preperitoneal space, deform this thing because it's got that rigid ring, and then stuff it into the inguinal canal, and it'll cover the myopectomy orifice just like a laparoscopic repair. That was the key. But early on, I don't know if you even remember this in the news, and it got very popular in the news. These patients were all being harmed by this device. But it's been fixed now, that the ring has been made so that it works, it doesn't fracture. So, but that's an open repair through a teeny incision. Next, this is a hybrid operation where you use both the preperitoneal space and the external space with this 2 pieces of mesh with this cylinder around it. And that's called the Prolene hernia system. Next. Okay, then let's go to laparoscopic repairs just briefly. TAP versus TEP versus IPOM, those are the 3. Does anybody want to tell me what the TAP versus the TEP versus the IPOM is? What's the TAP?
TAP is transabdominal
Yep.
preperitoneal.
Okay.
So you're going to go into the abdomen and
Okay.
you're going to create a preperitoneal plane, put it
Okay.
in.
Very good.
And suture
And
it
TEP?
closed. TAP is going to be totally extraperitoneal.
Next slide.
So that way, this you put that balloon into the
Yeah.
intraperitoneal or the preperitoneal space. You blow up the balloon and then you repair it without entering the abdominal cavity.
So you do like your Hassan technique, and instead of going into the belly, you just open up the rectus sheath, retract the rectus muscle laterally, and stick that balloon and hug it along the posterior rectus sheath right into the groin, and blow the balloon up. And basically, then you have the exact same anatomy as you do with the TAP, except the peritoneum's not open.
So-
This has gotten much less popular now because of robotics, because you really can't do this with robotics. You're gonna have to do a TAP. And I've done this many times, but I don't like it very well. I much prefer the TAP where you can really see things. Next.
The TAP is difficult because if you violate if your peritoneum ever opens up at any slight spot, you lose all your space.
Or if you tear a vein, it's just a bloody mess.
Yeah.
I
Well-
can't stand the tap.
Also with the TEP, I've watched a lot of people do them, nationally, internationally, and almost invariably, by the end of the operation, the patient has a pneumoperitoneum.
Yeah.
So there's gotta be perforation of the peritoneum, and sometimes we look, and you see a big hole in the peritoneum, but it doesn't seem to cause too much trouble. But it does cause trouble with TAP sometimes. But anyway, this is the typical anatomy, the critical features, what you gotta see when you do these operations. Cooper's ligament, cord structures, inferior epigastric vessels, femoral vein.
Yep.
And these are all crucial. Okay, next slide. Now, incisional hernias, do you want to get into the incisional hernias? Or do you want to cover that, Nick? I just thought I could get through the renals very quickly.
Yeah, my plan was to talk more about the cases towards the end, but I mean, whichever works
Well, I
for
mean,
you.
I've got a case at 11:45. I thought we got done about that time. But, I mean, we could, if you want to run through this, I can run through it quickly, and then I probably have to go.
Sure, and then we can just reinforce the points afterwards. Yeah.
I mean, is it helpful what I'm doing?
Yeah,
Yeah,
thank
absolutely.
you.
So, again, we have to have a classification system for any hernia repair, or any disease for that matter. So, anyway,
Let me just get
let's see,
these.
where are you going?
Or which? Sorry.
Can you go back to where you were?
One more.
Go back.
Good.
Okay, back, one more. Okay, this is the classification system. This is the European classification system. It's probably the most widely used. I won't go into detail, but you should just know that it's the most widely used classification system. Next slide. Okay, what really revolutionized incisional hernia repair and why there's all these new nuances nowadays, new operations, is this big study from Erasmus University. It was published in 2004 in the Annals of Surgery. And this was a multi-center trial in Holland between 1992 and 1998, and they had 181 patients with midline hernia incisions, either primary or first recurrent, and then they had a suture and a mesh repair. Next slide. So what was astounding and what just sort of shocked the hernia world was this massive recurrence rate. Suture repairs had a 63% recurrence rate, and even mesh repairs had a 32% recurrence rate. Next slide. And even the small hernias, less than 10 centimeters, the recurrence rate,
Oops, sorry.
the recurrence rate was unacceptably high. So this is what really changed our view of how we had to come up with a new approach to incisional hernias. Next slide. Okay. Prosthetic considerations, that's a lecture all in and of itself. Polypropylene versus polyester, it doesn't make any difference. The Europeans love polyester, Americans love polypropylene. I don't think it makes any difference. Heavyweight versus lightweight. Is that thing automatically mapped or
No,
something? I mean, I can skip this part.
No, it's
Because
fine.
again, we don't have to
No.
understand.
No.
Heavyweight versus lightweight. lightweight meshes became very popular, but we've seen burst abdomens, burst hernias, so I don't use it too much. The non-coated versus microfurnace versus coated. The coated meshes are the ones that we use inside the abdomen. For example, Ventrolite ST, it has a Seprafilm coating on it, so that it's safe to put inside the abdomen. You cannot put polypropylene or polyester inside the abdomen because it might erode into bowel. And then microporous, of course, that's Gore-Tex. That's more like a membrane, but we don't use it much, so I won't go on that. Synthetic versus biologic. The biologics have really fallen out of favor. They're so expensive and they don't work very well. The synthetics work much better. Hybrids are the things like phasics that you see now, where you got a mesh that maybe will stick around for a year and then go away, dissolve, and those have become increasingly popular, but again, very expensive. Next. Okay, conventional versus laparoscopic. Next. I mean, this is a typical pattern for a laparoscopic incisional hernia repair when you can do it. All the trocars are all on one side. You usually have to put them on the other side during the course of the operation because you can't staple the other way. The principle is you staple a piece of mesh after you close the defect, primarily with say something like a Carter Thompson device. Next one. Robotics have made it very popular to do these incisional hernias this way. You can do it either intra-abdominally or extraperitoneally if you want to. Next. Now this is what I commonly see with the hernias that I deal with, as most of you know. Huge separation of the rectus muscles. And you're not going to fix this with a robot or with laparoscopy. It's just too big. You're not going to be able to get those muscles back together properly. And if you try to just patch it, which is what was done in the early days, that's what this is showing, what you're going to get is pleating of that mesh with time, and the patient's going to be unhappy. They think their hernia's back. So we just simply do not do that anymore. Because this is what occurs. The patient comes and says, "Hi, my hernia's back." So, next slide. Okay, so just a quick rundown on the various prosthetic repairs that we're doing nowadays, trying to correct this problem of horrendous recurrence rates. You know, most of these recurrences were in sutured repairs, and that just doesn't work. So we've got an overlay, an inlay, and an underlay, which is a possible strategy. Next slide. We don't do inlays anymore. Whereas a tension-free repair, you'd think it would work great, just like it does in the groin. It's tension-free because you're not bridging the tissue, you're just suturing a prosthesis all the way around. But it doesn't work. The recurrence rate is almost 100%. It breaks down in one corner somewhere, and then they get another hernia. So we don't use it unless we have to. Next slide. But sometimes you have no choice. This is a patient with a burst abdomen, and there's no way we're going to get anything together there. So what we did with this patient is to do an inlay procedure, and then next slide, and then close the tissue, and then our idea is that muscle will come together a little bit, and we'll come back later and fix the recurrence later on and fix it properly. Next slide. Oops, I don't know where that came from. Did it go backwards?
No, it's going forward.
No, somehow I must have got the slide doubled somehow. Okay, this is the overlay. Okay, next slide. Okay, all these overlay procedures have the same principle in mind. The fascia is divided here like this. Next slide. Okay, see how you open the fascia here around the defect, then you reflect that fascia from the anterior muscle immediately and close it. Next slide. And then you're going to put something on top of that. That's how that's going to work. Next slide. The Chervelle procedure is probably the most popular. It's the same principle. You divide the anterior rectus sheath, move it inferiorly, and then his operation, he would sew external oblique to external oblique with his mesh. So he lays his mesh on that fourth picture there, and that's a lot of people have a lot of confidence in it, but I don't have too much. Next slide. Underlay, that's by far the procedure of choice for these for any incisional hernia repair nowadays. And this is the typical rectal rectus operation, which many of you have scrubbed on with me many times. You know, you open the rectus sheath laterally on either side of the defect, find the rectus muscle, and then dissect out the posterior rectus sheath, and that allows you to put a large piece of mesh beneath the rectus muscles after you've closed the fascia, the posterior rectus sheath in the midline. And then you put this large mesh in there, and then you close the fascia above, reapproximating the rectus muscles in the midline. Next slide. Okay, now, component separation, I only have about 2 or 3 slides left, so don't worry too much if you're getting bored. Component separation, the plastic surgeons started doing this with an idea, because they didn't use mesh, the idea to advance the rectus muscles, a good way to do it. And what they started doing was the external blank release. So they dissect the subcutaneous tissue and stuff off the fascia to get past the lateral edge of the rectus envelope, and then you open the external blank here, and that really, any of you've seen me do it, the underlying internal blank can be spread, can be pushed back, or this can be pushed back off the underlying internal blank, and it really advances the muscle. And then they just would close primarily. But of course, general surgeons, as soon as they started doing this, they would add a prosthesis because they're used to using prosthesis. So we do the same thing, but also put a rectus prosthesis. Next slide. That's the external blank release. Remember, there's 3 main releases that we do, 3 main component separations. 1, external blank release, which I just showed. 2 is the posterior rectus release, which we just showed. And now this is the 3rd one, the transverse abdominis release. Next slide. Okay. Now the principle here is that almost all anatomical diagrams in textbooks and in anatomy show the transverse abdominis muscle sort of hooking to the lateral edge of the rectus muscle. But that's not what really happens. It's more like over here. This muscle is more like over here. It's where the transverse abdominis inserts to the posterior rectus sheath. And so the principle here then is, next slide. Okay, so you can open the fascia and get in that plane between the transverse abdominis muscle. Now this is what you don't want to do right there, right? That's the nerves. You can't do that. So you get in here and you expose you divide the rectus, the transverse abdominis muscle vertically. I can't see it that well here. So by opening this up, you can see the transverse abdominis muscle. You just divide it and get in that plane between the transverse fascia. Next slide. And then see how this shows this here? So we divide the aponeurosis, or the muscle, medially, and then get in this plane here. Next slide. I think that might be it. Yeah, we won't get into this. These are adjuvant strategies. We don't have time for that. Okay, sorry.
All right.
Thank you.
No, thank you so much for your expertise on this.
So, can I do excuse though? 'Cause-
Yeah, of course.
1 more minute, you need to run.
Pardon me?
1 more minute, you need to run.
All right,